Hello and welcome back. This is Felice D'Arco, and I will like while I'm sharing my screen to uh, show you a presentation on pattern recognition in gray matter heterotopias. Actually, I'm by any means I'm not an expert in uh, brain malformation. There are a lot of groups that studied the classification of the brain malformation on both on genetics and radiological appearances. And I will suggest you some papers, but it's very, very important when you see something that look like gray matter heterotopia, how to interpret. In other words, how we go beyond the simple description of the lesion and its localization. So the question I would like to answer in these cases is how you define gray matter heterotopia and then how you distinguish gray matter heterotopia from mimics. That's very, very important. And again, I try to keep it practical, but I will also suggest you some interesting paper if you want to go in depth in the characterization of these pathological entities. The second is how we assess the gray matter heterotopia using magnetic resonance imaging. We will see some cases where this can be so subtle and need the right protocol. And I will discuss briefly about the protocol. And finally, two important things. When we see something that looks like gray matter heterotopia, can we tell our clinician this is most likely genetic or is most likely related to an insult, because both of these can be causes of gray matter heterotopia. And finally, I will show you some cases where we can use pattern recognition approach to do a genetic diagnosis in cases of gray matter heterotopia associated with other brain findings or in specific location or presenting with specific morphology. So let's start with the definition of gray matter heterotopia and mimics and read this paper on the classification of malformation cortical development by Maria Sabina Severino, the European Network on Brain Malformation group, and a lot of friends are involved in this paper. Is something that you should read. So basically, what is gray matter heterotopia? Is cluster of normal neurons, or not completely normal to be fair, but normal looking on MRI neurons in abnormal location. And this is likely due to an abnormal migration. Now, we have different types of gray matter heterotopia. The most frequent one is what we call periventricular nodular heterotopia. And this was previously called subependymal heterotopia, and is the most common type. There are, however, different subgroups of this that we can recognize and classify on images. For instance, the laminar heterotopia. That has been described in this paper. I will show you some example of all of that, but keep in mind that there are broad categories and then subgroups, and the subgroups can guide the etiopathogenetic interpretation, right? So second groups is the subcortical heterotopia. Again, I would suggest to read this paper from Professor Ogema on subcortical heterotopia gray matter. And subcortical heterotopia means areas of heterotopic gray matter located within the white matter between the cortex and the lateral ventricle. So it's not along the ventricular margin. Again, we can have some groups. The transmantle heterotopia from the ventricle to the cortex without the white matter in between, so cursing the white matter. And this is important because there are some mimics that we need to consider. And transmantle is divided in subglobal and ribbon-like heterotopia. We will come to that later. And then the subcortical band heterotopia. When you see something that as a radiologist you identify as subcortical band heterotopia, that's very important because these are almost all genetic in terms of etiopathogenesis. So basically, we have this island of abnormal gray matter in the white matter that we call subcortical heterotopia, but it's more complicated than that. Remember, several subgroups. And let's see them. This is the typical periventricular nodular heterotopia. Small nodules looking like normal gray matter on images. We know on pathology they are not completely normal. And again, guys, I presented this in the north of Italy in December 2023 on a beautiful congress dedicated to the approach to gray matter heterotopia and in children with epilepsy. And this is so complicated. The network they participated on is very, very complicated. So this is the first thing. Remember, they look like normal gray matter, but they are not completely normal. And this is the typical periventricular nodular heterotopia. The subgroup, laminar heterotopia, as you can see, is a smooth curvilinear heterotopic layer of gray matter with some associated white matter abnormalities and overlying abnormal cortex. So this is relevant when planning for epilepsy surgery. This is the subcortical band heterotopia, is a band of heterotopic gray matter in the white matter, very, very smooth. And when we see something like that, pattern recognition, think genetic, most likely with the DCX and at least one, but there are other genes I will mention. Finally, the subcortical transmantle heterotopia is a blob of gray matter going from the cortex to the ventricles, is associated with other malformation. Look at the dilatation of the ventricle, and this horizontal curve of the ventricle implies that there is no corpus callosum. Very, very important. Often this kind of gray matter heterotopia will be associated with a prenatal insult. So remember these appearances. And this is a subgroup of sublobar dysplasia, so-called brain in brain, and you can understand why it's called brain brain. And another subgroup called ribbon line heterotopia, with this ribbon heterotopic gray matter in both hemispheres. And this is again pattern recognition. Again, I will come to that later in the final part of this lecture, but think of this specific mutation ELM1. So transmantle heterotopia, some subgroups that you need to keep in mind. First thing first, distinguishing the gray matter heterotopia from mimics. So this is a patient with some nodules along the ventricular margin. Is this nodular heterotopia? Is a patient with seizure? Well, apart from that, keep looking, and there are a lot of areas of subcortical, cortical abnormal signal. These are tubers, i.e. for cortical dysplasia type 2B. This is typical tuberosclerosis. Some patients, this is another patient, same constellation of findings plus a subependymal giant cell astrocytoma, SEGA. When you see this constellation of findings, this is not subcortical heterotopias, but this is tuberosclerosis complex, and these are subependymal nodules. Now, another mimics, transmantle abnormalities associated with the dysplastic area in the cortex. This is the transmantle sign. This is not gray matter heterotopia. This is another case. These are actually they have the same histological appearances of the cortical dysplasia with balloon cells in this case because it was a type 2B. And this is a paper where they show the histology of that. So this is this part of the focal cortical dysplasia type 2B and is not transmantle gray matter heterotopia. It's very interesting, speaking about the surgical approach of the transmantle sign, that when it's close to very critical white matter tracts, speaking with our surgeon, they tend to do not operate if there is too much risk for the patient because it's unclear if this is epileptogenic, to the best of my knowledge. Okay, so we have seen these two mimics. Now we can see how we assess the gray matter heterotopia using magnetic resonance imaging. So this has to be isondense with the cerebral cortex in all the sequences. So this is why I told you before, despite the pathologists will tell you why these are not exactly normal neurons. For us as radiologists, we are a bit simple creature. They look exactly like normal gray matter. So to do so, we need to have several sequences and we need to compare the subcortical heterotopic or presumed heterotopic nodules with the normal gray matter, right? And you can see two examples in these cases, but also they dynamically behave like gray matter. We know from some studies that if the patient is seizing, look at this case with the nodular heterotopia during the periictal scan on diffusion, showing diffusion restriction which is transient together with the involved cortex. This is the same network, seizing network in the brain, different from the gray matter heterotopia on the other side, which is less bright on DWI and less dark in ADC. So there is a periictal diffusion restriction can be used to help you to pick up the small nodules or the active nodules of gray matter heterotopia as far as the network is concerned. Very, very important. And very important to do the right sequences. This is our gauche epilepsy protocol. We are adding more sequences, artificial intelligence, software, MELD. There are other, but MELD is done by the UCL group, and I will put the link in the description if you are interested. This is open source, and they are very open to new people to join this network of people using MELD. We are using MP2 Rage, arterial speed labeling, diffusion for preoperative planning, and so on. But it's very important that you have 3D sequences in order to pick up the small abnormalities in the by way of small nodular gray matter, for instance, right? So use 3D sequence, 3D T1, and FLAIR 3D are the best sequence that we use. And now that we know how to call, we know how to pick up on a scan, even the smallest nodule of gray matter heterotopia, what we do with that, how we interpret that. And this is what I as a clinical neuroradiologist, was what I tried to figure out when I studied for this presentation. And the answer is, to some extent, we can distinguish between genetic and non-genetic cases. And in fact, the pearl for your differential diagnosis is that when there are other stuff that we know are most likely destructive in nature, then we can say, oh well, this is probably gray matter heterotopia non-genetic in nature. And I will show you some examples. Important though is that there are some genes that create, especially prenatally, destructive vascular event, like COL4A1, for instance, right? So you need to basically keep in mind this. So there are destructive events that are related to genes. So this is very, very important, and you need to keep in mind. So other pitfalls that much more genes and chromosomal abnormality are coming out more and more from recent literature. So you need to be updated, and you need to have a constant productive dialogue with with your geneticist. So what are these destructive things? First of all, Dandy-Walker malformation and gray matter heterotopia. Think prenatal destruction. Why? There is another lecture on posterior fossa cystic abnormalities that you can check out. There are also beautiful papers suggested there that you can read. But as far as this lecture is concerned, we know now that Dandy-Walker, like in this case, malformation, and please remember there are new criteria that have been published by Dr. Whitehead and Professor Mankad, so check it out. But as far as this lecture is concerned, as I said, Dandy-Walker and gray matter heterotopia, like in these cases, you see, periventricular heterotopia and Dandy-Walker, you need to think of an insult. I will tell you why in a moment, but look at these cases. There is very destructive looking brain, abnormal corpus callosum, small pons, Dandy-Walker, this kind of brain-in-brain gray matter heterotopia in this case published in 2019 that suggests destructive event. This is a case from Ghosh. In the row below, you see nodules of gray matter heterotopia, but also a cleft and Andy Walker and loss of white matter bulk. All of these are radiological signs that suggest an insult rather than a genetic cause for the heterotopia. So think heterotopia. Also, the posterior location of the gray matter heterotopia is less likely to be due to a genetic cause. So Dandy Walker is one of these association with gray matter heterotopia that should make you think more likely insult than genetic. But why is that? Well, there are some papers, and this is a beautiful paper from Dr. Aldipur showing the histopathology of Dandy Walker versus genetic causes of vermis hypoplasia. On the left, another paper from the group of Bill Dobbins, and they all demonstrated that actually there is a major contribution of non-genetic prenatal factor in cerebellar abnormalities. In particularly, Dandy Walker is unlikely to be associated with the genetic defect, unless, of course, a genetic defect creates a prenatal insult, like I showed you before in the pitfalls. Yeah. So we know that Dandy Walker is most likely due to prenatal insult. We know that Dandy Walker can be associated with gray matter heterotopia. We put together this and we think non-genetic. So we can call our geneticist or neurologist and say, well, we think that this is most likely non-genetic. Another cause is when it's associated with polymicrogyria and transmantle heterotopia. Look at this case. There is a transmantle heterotopia, almost a closed-lipped schizencephaly, with also some nodule of gray matter heterotopia along the ventricles. And we know that, again, that's another beautiful paper from Professor Griffiths in Sheffield that basically hypothesized that because the brain cannot create gliosis, the fetal brain cannot really create gliosis, if there is an insult quite early on in the gestation, the way the brain reacts is to create abnormal gray matter. And this is why polymicrogyria can be a sign of vascular insult in early fetal life, and schizencephaly is also due to, most likely, to a vascular insult. It's also important that if you have schizencephaly, gray matter heterotopia, especially if bilateral, again, you test the genes like COL4A1 or COL4A2 that are known to give fetal and early life vascular insult. Okay, so destructive theory for the formation of schizencephaly and polymicrogyria can be associated with gray matter heterotopia. That's another case. So please think prenatal insult. And also, if there are things in the face, in the craniofacial appearances that are most likely to be non-genetic, like a frontonasal dysplasia, look at this case with abnormal frontal bones that I reported, and I figured out that there were some nodules of heterotopia periventricular and also some transmantle gray matter heterotopia. So this has been reported again by Professor Guerini and Professor Dobbins, and so there is an association with frontonasal malformation, gray matter heterotopia, probably again related to a prenatal insult, and the genetic tests that we have done on these patients were actually negative. So let me show you now what about the genetic causes of abnormality in the brain associated with gray matter heterotopia. So let's go from some pattern recognition approach. So pattern one, subcortical band heterotopia. I told you before, think always genetic, and these are LIS1 or DCX. The gradient can be a bit different, but there is a lot of overlap. LIS1 is more posterior but there is a lot of overlap, and 80% of the subcortical band heterotopia are LIS1 or DCX related. However, remember that there are also some other causes of posterior band heterotopia with anterior package area that can be related to ACTB, ACTG1 genes. So basically you do the panel, and there is a beautiful paper by Professor Di Donato in 2017 that classified the lissencephaly spectrum. It basically shows that there is a lot of overlap and you need really to run the panel. And this is just from the paper showing all the different characteristics of the genes associated with lissencephaly. Yeah? Pattern 2, you have periventricular nodular heterotopia, Grey Matter Heterotopia, and you have two clinical scenarios. We know, most of you probably know, filament A, bilateral frontoparietal, so anterior and superior localization of this multiple nodular Grey Matter Heterotopia in female. Average cognitive ability, they can have seizure, cardiovascular risk factor, other abnormality in the brain, but they are doing quite well as far as the neurological development is concerned. However, something very similar with only associated abnormality in the puttamina can be found in male and female, and is due to EF2 genes, very difficult to pronounce, but in these cases, the child has spastic diplegia, microcephaly associated, developmentally, they are not doing as well as filament A. So the same pattern, slightly different association, completely in the brain, completely different clinical scenario, will guide you toward the different genes. And of course, in a world full of variant of unknown significance, you need to know these patterns, these radiological patterns, because you help the geneticist and the neurologist in identifying if a variant is pathogenic or not. Pattern 3, this child is deaf. That's a very important clue. Has periventricular heterotopia, but much more. Look at this. This is from literature. The corpus callosum is abnormal. There is a supravermian cyst, bilateral periventricular heterotopia, and polymicrogyria. You can see also here colpocephaly due to the abnormal corpus callosum and inferior cerebellar dysplasia. So partial genesis of the corpus callosum, frontal polymicrogyria, nodular heterotopia, colpocephaly, cerebellar hypoplasia, dysplasia. This can be non-specific, but in association with all these findings and deafness is very typical of Chudley-McCulloch syndrome due to GPSM2 mutation. Why? To recognize this constellation of findings is critical for you as a radiologist, and especially if you do fetal scans, because despite the brain looking very bad in this case, what we have is actually a decent neurological outcome, and so very good prognosis. So when counseling about termination of pregnancy, recognizing Chudley-McCulloch syndrome in a fetal scan is extremely important. Finally, peritrigonal heterotopia microcephaly. I need to thank my colleague, Dr. Sudhakar, that taught me this pattern. And you see this periventricular peritrigonal lump of gray matter, almost some wings here with associated abnormal corpus callosum, very microcephalic with developmental delay. And this has been also published here. There are two genes, either CHEMP-J or CHEP135 that present with this typical peritrigonal temporal areas of periventricular heterotopia. So you can basically suggest these two genes. And this is very important. I love radiology because the more you study, the more you know, the more really you can contribute to the diagnosis, and again, makes the life of geneticist much more easier. Finally, the ribbon-like heterotopia, very typical, very specific, is EML1 associated brain overgrowth syndrome. So this is again pattern recognition. You see something like that, you cannot forget anymore. It's very typical, very striking, and suggests, to the best of my knowledge, one and one gene only. So what are my take-home messages? Right MRI protocol is essential to diagnose gray matter heterotopia. You need high-resolution sequences. More and more genes are associated, but do not forget prenatal insult and look for associated causes or associated findings that suggest a prenatal insult, like schistoencephaly, cleft, loss of white matter, Dandy-Walker malformation. Pattern recognition approach can help geneticists and clinicians, so you have an important role that is not only to describe the abnormalities, but try to name them. And do not forget the mimics, and I show you tuberous sclerosis, thrombus focal cortical dysplasia. My lecture are all on YouTube, so please check out the channel if you are if you like pediatric neuroradiologists. It's very important though that my lecture are quite basics, and I suggest a paper that helped me in learning this topic I'm speaking about, and I will put some useful links in the description. And there are several international societies that provide very nice lecture on YouTube. So also on YouTube, and also free for all. So please check them out. And again, the link are in the description. Thank you very much, and see you next time.